Hello everyone, I'm Mary Maguire, Director of Public and Legislative Affairs at AAA Northeast, and welcome to Community Forum. I am normally a guest on this show with my friend Roy Cohen, but today I have the special privilege of hosting, and I also have the privilege of talking with a very distinguished guest, and I think you're going to learn an awful lot from her. She is Dr. Susan Stafford. She is a radiologist and Director of Breast Imaging and Intervention at Good Samaritan Medical Center in Brockton, and she is also going to be talking about the breast imaging facility in Easton, Mass, when we speak with her today. So welcome to the show, Dr. Stafford.
Thank you for the invitation.
Absolutely. Thanks for being here. I think this is going to be a great conversation. So let me start out by asking you, tell us about yourself. What's your background? I understand you were actually a television reporter at one point before you became a doctor.
Not really a reporter, but I have been here in Brockton since 2004. I very much enjoy working here in this part of the state. I have found a good home at Good Samaritan Medical Center. I trained in Boston at Mass General. I worked at Emerson Hospital in Concord for many years, where I was part of a group that started one of the first breast imaging facilities in the country. We were the 6th accredited facility in the United States. I've been involved in organized medicine. I've been part of the mammography committee of the American College of Radiology here in Massachusetts, and was involved in writing some regulations back in the early 1990s when the government got involved in overseeing the quality of breast imaging.
So why are you so passionate about breast imaging? Why is it so important to you? And considering all the different things you could have focused on or concentrated in, why did you choose breast cancer prevention and imaging?
Well, actually, I'm a general radiologist, and I provide services at Good Samaritan in almost all parts of medical imaging. I was trained as an abdominal imager after I did radiology, but during my residency training, I was trained by a very famous breast imager who caused many of us to develop a high sense of responsibility for this. I think that the nice part of breast imaging in radiology is that you get a chance to be part of a team that's integrated and providing service to patients and interacting with the patients more than the average radiologist who's interpreting images more than talking to patients.
I see. So my mother was a breast cancer survivor very early on. She was diagnosed in the early 1960s, and she survived another 20 years, which is terrific after she was diagnosed. But I've always been vigilant as a result. I started getting mammograms very early. I always went once a year. I've always gone once a year, etc. A lot of people put off their mammograms. They don't feel perhaps that they want to go. They are worried that the mammogram will be uncomfortable. How can you, first of all, allay these fears for people, and why is it so important for all of us, men and women, to make sure, at least in the case of women, that we're getting mammograms and that we're getting annual mammograms, especially if we have a family history?
I think the last few years have caused a lot of confusion and uncertainty on the part of women because they've received so many mixed messages. And radiologists in the Society of Breast Imaging and the American College of Radiology, also the American College of Surgeons, currently endorse a program called End the Confusion. We recommend that women that the average patient, the average woman, have her first mammogram beginning at age 40, and that she have an annual mammogram thereafter. That's screening. A screening examination is performed in a group or population of patients who are identified as at elevated risk for a diagnosis. We're at elevated risk because we're women. And people who are at average elevated risk should have an annual mammogram. The age at which one stops having the mammogram is a personal choice based mostly on other health issues, because we have solutions for women of all ages that are different based on ages and the type of cancer that one has. And this year in the United States, they're expecting something between 230,000 and 250,000 new breast cancers. Wow. 20 to 30% of those are expected to be diagnosed in women between the ages of 40 and 50. So that we do support women starting their annual mammograms beginning at age 40. And screening does involve having the study annually. It's not one and done, because you need to monitor the breast in order to catch the cancer early. We can't prevent a cancer, but we do have the capacity in many instances to make sure that cancers are diagnosed earlier when less treatment is required.
So that's interesting. So 40 becomes the baseline, in other words.
Used to be 35, but now it's 40.
And why did the number, the age move from 35 to 40?
The advantage of having a mammogram at 35 as a baseline and then not having another one to 40 didn't pan out with the data. So some people who have a higher risk are recommended to begin before 40, but that's based upon things like family history, genetic makeup, certain populations, women who have backgrounds with Ashkenazi Jewish relatives have a much higher risk of breast cancer.
So in other words, if a woman does have a family history, as I did with my mom, or if she has aunts or sisters or something like that, then perhaps she should speak with her doctor and consider getting a mammogram earlier than age 40. Is that correct?
It would depend upon the information.
Okay. So you seem to be saying, Dr. Stafford, that everyone's case is different and everyone's case is unique to some extent. Is that true?
That is true, but all women should begin by 40.
Okay, all right, so great advice. So go out there and get your mammogram.
Yeah, we'd love to see you.
Yeah, that's the first message we want to send. So you said we'd love to see you. Tell us about your facilities. Tell us about Good Samaritan Medical Center and about the Women's Imaging Center and what both these facilities do and what they can offer to women and to men.
Good Samaritan Medical Center is a full-service community hospital in Brockton, Massachusetts. It's part of the network of hospitals of Stewart Healthcare. We have a very active emergency room, and we provide other typical services provided by community hospitals in Massachusetts. Our women's imaging facility is located in northeastern Massachusetts, about 3 miles from the hospital, and we're in Roach Brothers Plaza in an office building. We're on the first floor. There's plenty of free parking, and access to the facility is very simple from the parking lot or from public transportation that comes to the building.
So is that where you practice?
That's where I spend about 2/3 of my time.
Okay.
Otherwise, I'm at the hospital.
Okay, I figured you split your time between the hospital and the imaging center, so that makes sense. It seems as if many hospitals today and hospital networks are creating these community facilities. Is that something that that was done to give people in the community better access, for example, or another option? Tell us a little bit about the philosophy that led to the creation of the center 4 years ago or so.
Traditionally, separate women's imaging facilities have been constructed and planned because the patients who come to these facilities are not sick. Most of them are not symptomatic. Most of our patients are well, do not have any medical problems, end up having a normal mammogram. So they usually feel more comfortable coming to a destination where people are not sick.
That certainly makes sense.
And it also is just easier for them to come to an outpatient facility. If all women over 40 come annually, that's a fairly big volume of people coming through a facility every year. And most of the women's imaging facilities in Massachusetts are very busy places, not just ours. And so we need to have enough parking close by and a lot of room for the flow of people in and out.
You know, it's interesting, and I saw some pictures of your waiting room earlier, and it looks very comfortable. I do think that plays a role. Parking, accessibility, comfort, going to a place where you feel comfortable, and a place that feels warm, because I think that if you feel comfortable going to a facility, you're more likely to go in and get the screenings that you need. Do you think that's true?
Oh, I definitely do. We have a very stable group of technologists, for instance, even our receptionists who've been there for years. And many of our patients will come in and they want to have their mammogram done by the woman who does their mammogram every year. It's not just their doctor, but they have their own technologist.
So it's a whole team of people, and your patients really forge relationships with members of the team. It's not just the physician and the nurse, as you say, it's the others who are working there as well.
It's a team-centered imaging practice. We have receptionists and schedulers. We have 2 RNs on site. We have 1 or 2 physicians every day, and we have a very large number of technologists. As I say to everyone, everyone needs to know everyone else's job in order to get the patient through the system in a meaningful fashion. And I think we have that team. I mean, it's really helpful. We're lucky to have 2 nurses. They are there to navigate for the patients, to help them during procedures, to help them with their communication with other physicians if they need follow-up. We have someone to schedule appointments. All of our patients who have biopsies are scheduled with a breast surgeon to receive their results so that correct decisions are made on behalf of the patients once they get their biopsies.
Dr. Stafford, can you talk about the role of screening in breast health, and can you talk about the different types of screening that might be appropriate for different patients?
The most common screening that's done in our facility in the United States is a digital projectional mammogram. It's an X-ray picture of the breast where the image is projected onto a detector. Typically 4 views are done, 2 of each breast for screening. The second most common examination that's performed for screening is tomosynthesis. Tomosynthesis, also known as 3D mammography, is a technique where the image is collected from multiple different positions, and then the computer integrates the information into a 3D volume and then takes that data and generates slices that we look at. And that allows us to better see some of the secondary effects of breast cancer, some of the scarring and architectural distortions, and allows us to see things that are frankly difficult to detect with conventional mammography.
Interesting. So I have a 3D mammogram, which I actually requested, and I guess I'm wondering now, should I be doing the digital projection instead? Is one better than the other, or does it depend on your situation as a patient?
The literature shows that the 3D mammography picks up more breast cancers that present as masses and as architectural distortions. Cancers that present as calcifications are sometimes, but not always, better seen with the projectional mammography. Both of them are excellent techniques, and most places have both. Some places have only the tomosynthesis or only the projectional. They're both very high quality, and it's difficult to say. But I would say that the literature shows that there is a benefit to having the tomosynthesis for most women.
How would you counsel a woman who is very nervous about having a mammogram, has not had a mammogram perhaps, or is having one for the first time, or is putting off a mammogram when she shouldn't be, for example, someone who's over the age of 40, for example, given your guideline and recommendation? What would you say to that person to encourage them?
Well, you're not alone, I would say. It's very common to have these feelings of uncertainty, or even some women feel a little embarrassed to come in if they're over 40. They feel like maybe they haven't done what they were supposed to do. We don't really care. And
you're just glad they're there.
Yeah, and all are welcome at our facility with any symptom, with any sign, with no symptoms. We'll help you through the process. Our technologists are used to making people feel very comfortable with the process. And I would also say, don't let others tell you that you should feel anxious. There have been a lot of people who've recommended not having mammograms because they make people feel anxious. Well, I think that's a little patriarchal, and I think that we as women can work together and manage our feelings about this, and we'll help you.
Well, you know, it's funny. I always feel great after I have a mammogram, especially if I get a positive outcome, because you feel healthy, you feel like you've been proactive about your health. So there's so many tremendous positives. And as I said, my mother was a breast cancer survivor, and so I was always very diligent about getting my mammograms every year. And I think it creates such a tremendous feeling of security for people. So that's interesting about the anxiety. Why is early detection so important?
Early detection is important because survival is improved in women who have a low-stage breast cancer, meaning they have a smaller tumor, they have fewer extensions of tumor to the lymph nodes in their armpit, and they're less likely to have breast cancer that's spread beyond the breast if they have an early diagnosis. In addition, women who are diagnosed early require less treatment. And that means that if one happens to be someone who has a breast cancer recur or a new breast cancer that shows up later, that they have more options still available to them because they haven't used them up yet. So, I think it's about early detection and treatment. If you look at deaths from breast cancer since 1990, most breast screening programs in the United States began in the late 1980s. And there was an initial rapid reduction in death due to breast cancer. But it's continued because in the mid to late 1990s, there's been continued benefit to women because we've had new treatments that have evolved and new information related to how the treatments should be deployed that have been related to all the research that began in the 90s.
So I'll tell you a little bit about my story, because not only was my mom a breast cancer survivor, but I'm a breast cancer survivor, and I was actually diagnosed very early in the stage process when I was 56. And so I'm considered cured now. You can tell me whether that's true. I hope it's true, but that's what my doctors tell me because of the fact that my cancer never spread. I had a lumpectomy and then radiation. But the great thing was that because I was diligent about getting my mammograms, the cancer that I had was detected very early, and it was very small. There were actually 3 small lesions. So I just want to encourage all women out there to get mammograms, to get regular mammograms. If you are over the age of 40, going with your recommendation, because it really can save your life. And the treatment was so much easier for me because I ended up having a lumpectomy, a lymph node surgery, and then I had radiation for about 2 to 3 months of radiation. And since then, they've been monitoring me. That's, I think, another advantage of treatment is that you are monitored and watched regularly after that. Certainly I've had wonderful doctors and nurses and technicians and technologists who have taken such great care of me, and we have so many wonderful hospitals here in the Boston area, including Good Samaritan and your center. So I feel like I'm in a good place right now because I feel like not only am I being vigilant, but I have this team of people who's also being vigilant. So I don't know if you can speak to that, the importance of that, of not just the early detection that we talked about, but the fact that the treatment is so much easier. I mean, I have another friend who had a similar experience, and she describes it as a speed bump in her life. Not everyone is that fortunate, obviously. Some people are diagnosed at a more advanced stage, and they have more aggressive forms of cancer, et cetera. But anyway, if you could talk about that a little bit.
Breast cancer is a very treatable entity. Women 96 to 98% of women with breast cancer tell your story. They tell the story of how they are cured by their treatment.
Which is so wonderful.
And not all of the other women, but many of the other women, as I said to you earlier, coexist with their disease because we have amazing treatments and doctors, especially in Massachusetts, we have excellent centers for breast cancer in Massachusetts.
We sure do. We're lucky.
All of them are very good. And people know how to treat this disease. And I think that everyone will be treated well no matter where they go in Massachusetts. I'm certain of that. And I have many colleagues at many different facilities around the state.
And as you were saying, you were trained at Mass General, et cetera. So, I think there are many physicians like that who have spent time at different institutions and have gained expertise at each one of them, I'm sure. I think that's such an important point to make, too. You use the phrase coexisting with cancer. And I think that's so important for people to know that you can go through treatment in so many cases and continue living your life and have a good quality of life. And when I was first diagnosed, I remember I just started to cry because I really saw it as kind of a death sentence. When I first heard the words, "You have cancer," or "We have found cancer," from my doctor, who I had known for many, many years. And the first thing she said to me was, "Don't cry." She said, "There are so many people living with cancer," to your point about coexisting with cancer. She said, "Do you know how many patients I have who are living with cancer?" And I didn't really understand what that phrase meant until I had two friends who were diagnosed right around the same time I was. I have another friend who's just started treatment within the last couple of weeks. And I think I understand what that phrase, living with cancer, means now, but I think in the beginning, it's a shock and you don't really understand how that works completely.
It's very frightening.
But
I think that, as I said, every place in Massachusetts has very experienced physicians and teams around them who know how to treat and support patients with breast cancer.
It also seems as if, Dr. Stafford, that the treatments keep getting better and more individualized. Do you think that's true?
I think it would be outside of my area of expertise to really speak to that with any knowledge, but based on what I see, I know that when we go to tumor board and we review all of our patients, we make decisions based on a lot of issues: the cell type, the extent of disease, the patient's body habitus, their other medical problems, their age, but most of it is driven by the science and the data. The ultimate decision is almost always made, or recommendation is made, based on the science. We have a lot of data for breast cancer.
Which is terrific. One of the things that I find confusing, even though I've been through this process to some extent, are the different types of treatments that are offered. So can you talk a little bit about, let's say I or another woman has had the mammogram, but do I need an ultrasound? Do I need a needle biopsy? Do I need ultrasonography? What are some of the other kinds of treatments or scans or screenings that are offered, and how do you know that you need, let's say, an MRI or something beyond the mammogram?
Well, I think to look at it a couple of ways. If you look at conventional screening of a patient of average risk, that patient will have a mammogram. If the mammogram is normal, they're going to receive a letter from the facility and the physician. It's required by the federal government, by the FDA, telling them that their examination's negative and that their next mammogram is due in a year. If there's a finding on the mammogram for which further information is required, they're going to be contacted by the facility and asked to return for additional imaging. The type of additional imaging that's performed at that time is based on the finding. Is it an area of increased density? Is it a possible mass? Is it possible calcifications? That will determine whether or not it's more mammograms and ultrasound or just more mammograms. Once that information is collected, in every place I've ever been, the physician reviews the images while you're still there, makes a determination as to whether or not it's negative, probably normal and needs a short interval follow-up, or requires a biopsy. And depending on the patient population and the facility, usually it's related to the patient population. If you have a stable patient population where everybody's coming back every year, about 5 to 10% of patients will get called back for additional imaging. If you have a population where you tend to have a lot of people who don't come every year, you're going to have a higher callback rate because you don't have old mammograms on people, maybe 15%. But most people who get called back end up being recommended for a next mammogram in a year. A small percentage of those patients do need a biopsy. If you look at all patients biopsied at our facility and pretty much nationally, about 80 to 85% will end up with a negative biopsy. No further additional assessments required. We usually do one more 6-month follow-up to make sure there wasn't a sampling error at the time of the biopsy. But most patients, even those who get a biopsy, don't have breast cancer because the examination isn't perfect. In terms of people who require a higher degree of or a higher level of screening, if you look at people, for instance, who have the BRCA gene, which is the breast cancer gene, those women are usually recommended to begin their screening either at age 30 or 10 years before the age of their family member who is diagnosed with breast cancer. So if your mother were diagnosed with breast cancer at the age of 34, we'd probably bring you in at 24 or 25 to start your mammography. People who have the BRCA1 gene, or people who are of Ashkenazi Jewish descent, or who have very strong family histories of breast cancer and who have been shown to have an elevated more than 20% risk of breast cancer based on baseline, they're going to be recommended for an MRI to be performed annually in addition to mammography. That's not a very big population in the community. Many women who are at elevated risk go to special centers. There are special centers at all of the downtown hospitals. We do screening of people with elevated risk at our facility as everywhere. But so you have that in tandem so that you have a screening study every 6 months. So you get an annual mammogram, say in January, and then an annual MRI in July. So you get one study or the other every 6 months, but each one is done annually.
Okay, that sounds like it would be very, very effective. We've talked about the different types of screenings and what they consist of and the BRCA gene. What about self-exams, Dr. Stafford? How important are self-exams in the context of what we're talking about?
Self-exams are no longer officially recommended by the American Cancer Society, but most of the famous cancer hospitals like Memorial Sloan Kettering still promote self-examination. Women, even those who don't perform an official monthly self-examination, will often find their own breast cancers. Women who feel their own breast cancers, women know what their own breasts feel like. And so we take that pretty seriously. If someone feels a mass, or if your doctor or your husband feels a mass, we want to see you. We want you to call us, come on in. We'll make sure your doctor gets you a referral if that's necessary. We'll help you with that, as will all of the other facilities in the state.
So I actually had that experience too. I actually found 2 benign tumors, or I felt something that they turned out to be 2 benign tumors when I went to my doctor in 1993, shortly after my doctor was born. And I found those on a self-exam, and I had actually recently had a mammogram. So I'm sure the screenings have improved greatly since 1993. But does it make sense to continue to do a self-exam given the fact that mammography sometimes does miss things?
We strongly support it. Women should do their own self-examinations. I think women do that. Mm-hmm. It may not be quite as organized as having a shower card with something to check off every month, but I think when people bathe, they check themselves, and they know they know what's new. Women know.
I think so too. I think people know their own bodies, especially as we get older. I think you can tell when something is a little bit off. I think that's very true. So I think that's a great recommendation. So let me ask you this. Let's talk about risk of breast cancer, because I think prevention is so important in this day and age, and we know a lot more about prevention. So what I've been told, for example, by my physicians, is that exercise plays a really important role in boosting your immune system and in prevention. And I know there's talk about plant-based diets and obesity and all of these other things as factors. Can you talk about that a little bit? What raises risk factors aside from family history, which we've talked about?
Well, family history and the BRCA gene are, of course, the highest issues, but there are also other issues to consider. Chest irradiation, so radiation of the chest, especially in a teenager, raises the risk significantly. So that and we learned that after we learned how to treat Hodgkin's disease with radiation therapy. Hodgkin's disease of the chest is often a disease of a teenager, and when that's a female teenager, they have to begin their screenings 10 years after their radiation therapy. So we like to see them usually beginning in their 20s, because they have a very high risk of developing breast cancer, especially in the port from the radiation, which is in the inner part of the breasts. Women who've been exposed to radiation for other causes, for instance, women who've had a lot of x-rays as teenagers for scoliosis, they're potentially at an elevated risk, depending on how many x-rays they had, how much of their breasts were involved, and the equipment that was used to x-ray the breasts. Same is true if you look at women who were at Hiroshima and Nagasaki, women who were teenagers at that time.
Wow, I did not know that. That's so interesting.
Yeah, the literature shows, actually it was a famous group here in Boston who did that original work on the women who were irradiated for Hodgkin's disease and the elevated risk of breast cancer. And so that is a major risk. In terms of the environmental issues, I think we're all concerned about environmental issues. There's no question that obesity is a risk factor. Fat in the body is a reservoir for estrogen and can lead to higher estrogen levels. We don't recommend, I think there were studies done at the Brigham that showed there's an elevated risk of breast cancer for women who take exogenous hormone replacement, who do it for prolonged periods of time, so that it's now recommended that women who need or require hormone replacement for symptomatic reasons or other issues, that they limit that to as short a period of time and as low a dose as possible. There is no risk that's been documented in women who receive hormones for infertility issues. I think that's an important thing to realize. We don't have any data. People worry about that a lot, but there is no data to suggest that those women are at elevated risk.
That's good news. Very interesting, though, about the radiation for previous cancers or that was done therapeutically for medical reasons. What about going through the x-ray machine at the airport? Is that something that I should be worried about?
I don't think so. I mean, that's a very low dose radiation. I mean, I think if you're pregnant or you have teenage daughters, would I put them in the x-ray machine? I probably wouldn't. I mean, you have the option of sending your teenager through the metal detector.
That's a good suggestion and recommendation. I would not have
I don't think there's any reason to expose yourself to unnecessary radiation.
What about increased exercise, plant-based diet, avoiding red meats? We hear about carcinogens, some of the environmental things that you referred to. What I have been told, and by my doctors, is that the proven immunobuilder is exercise, that there's no real evidence for plant-based diet making a difference, that all the dietary things, there's not really the proven data there, but that exercise can be helpful. I don't know if you agree or disagree.
I'm really in favor of that for mental health as much as to prevent cancer. I can't say I have any expertise in that issue.
Right, as a
I think I read the
radiologist,
same thing that everyone else reads, but you know, I mean, meditation, exercise, and sleep. Sleep is my favorite form of therapy for all problems.
I agree with you. I think sleep is underrated, especially by our society where we're so go-go, especially in the Northeast, and people brag about how little sleep they can get by on. But as I get older, I'm trying to sleep more.
Yeah, and I think the things that people want to do to protect our planet, you know, to reduce the pressure of pesticides and chemical fertilizers, I think that's got to be beneficial.
I agree with you. So we are going to take a short break to thank our sponsors, and then we are going to come back and talk with Dr. Stafford about whether or not men are at risk for breast cancer.
Hi, it's Gary LaPierre, and the crew wants to thank Maxie's Delicatessen. That's at 117 Sharon Street in Stoughton. They're 781-341-1662. American Cancer Society, yes, they're looking for volunteers. Drive cancer patients to and from their treatments. 1-800-ACS-6662. Or just go to www.cancer.org. Ilsa Mark's Food Pantry in St. Anthony's Free Market, 2 Park Avenue in Stoughton. For more information, call Christine Gallagher. That's at 781-341-0611 or 781-341-0549. Meals on Wheels. Just ask for Jessica. You'll find her at 781-344-8882, extension 2. Stoughton Penny Saver. Our business is advertising your business, they tell us. 27 Rose Glen Street, Stoughton, 781-344-4833. Community Forum showtimes in Stoughton. It's Thursday, Friday, Saturday, and Sunday at 6 p.m., Monday at 8 p.m., Tuesday at 5 p.m. It's on Comcast Channel 9 and Verizon Channel 28. All comments and suggestions welcome. Contact us at communityforum1@yahoo.com. Samaritans, they're at 41 West Street on the 4th floor in Boston, 02111. Their phone number is 617-536-2460. 24-hour helplines for Samaritans, and the number is 877-870-HOPE. That's 877-870-4673. Samaritans, you can find them at 800-252-TEEN. That's 252-8336. Or find them online at SamaritansHope.org.
And we are back with our special guest, Dr. Susan Stafford, radiologist with Good Samaritan Medical Center and with the breast imaging and intervention. She is director of breast imaging and intervention for Good Samaritan, and also spends much of her time at the Women's Imaging Center in the Roach Brothers Plaza in Northeastern Massachusetts. So terrific conversation we've been having. I've learned so much already. Let's talk about men. Are men at risk for breast cancer as well as women?
It's a very uncommon diagnosis, but men can also develop breast cancer. They can have the same kind of ductal cancers that women get, but they can also have other more unusual cancers that arise from the supporting tissues in the breast because they don't have as much glandular tissue as women.
So that's good to know. It's always good to know that it's rare, and I think that makes a lot of people feel more comfortable, but still important to know that it's out there, that it can happen. Obviously far more common in women. Let's talk about the process of the mammogram, the initial annual screening itself. So during the break, we talked about the fact that there are some people who are anxious about getting mammograms, not because they're worried about the procedure itself or the outcome, but they might not feel as comfortable with their bodies as other patients do, and they might feel anxious about that part of it. Can you talk about the fact that it's really a judgment-free zone at your facility, and why that's so important to good health care?
Yeah, I mean, I think that there are a lot of barriers to taking care of ourselves as human beings that are related to anxieties we have about ourselves and our worthiness. And some people are uncomfortable disrobing in front of other people, or afraid they may be asked to disrobe or be in front of other people when they do disrobe. We see patients who are concerned about that oftentimes during our evening hours that we provide, because there's a little more privacy. There are fewer people there for their screening. I think we also take care of patients who are anxious in general about being in a public place and feeling potentially that they're not worthy of being cared for. Sometimes that's socioeconomic or related to how potentially they've been treated in the past, or to emotional issues. I will say that we're familiar with that, and we're very comfortable with it. And our technologists not only are empathetic and kind to people, but I would say for the most part, I hear a lot of laughter out there.
Which is terrific.
Right. And at our facility, we have some of the nicest patients with whom I've ever worked. And they're supportive of each other in the waiting room. We have people who don't speak English. We have people of every color. We have people from every part of society sitting together. And I remember we had a piece of equipment go down one day, and I heard a patient say, "All right, I'm going to pass around this piece of paper. I'd like everybody to sign up for what they want. I'm going over to Dunkin' Donuts, and I'm getting something for everybody."
Oh, wow, what a great person.
So I think it's it feels that way to me there, and I want patients to feel supported as well when they're there.
So everyone deserves great care, in other words. It doesn't matter, as you said, it doesn't matter what color you are, what situation you're in, what your body looks like, and everybody deserves great care.
Right, and if you don't speak English, we have translators on the phone. Sometimes they're in person. Usually we have to schedule that, but if you have to have a procedure and English is not your language that you speak, we always get an on-site interpreter to help you during the procedure, as well as our nurse or tech or doctor who's there with you as well.
That's great, and I bet a lot of people don't know that, especially if there is some kind of a language barrier or concern, so it's great to know that you have that person available.
And when we need to speak to people on the phone, we get a three-way conference going with the interpreter and the nurse and the patient. We're used to this.
That's terrific. And I agree with you about the laughter part of it. I mean, we're all human. We all go through this. We all have to have our mammograms and our screenings, and it's part of good health, and it's part of being human, and everybody's human. Everybody has the same concerns and fears and anxieties, I think. So, you had said earlier you're not alone, that was one of the messages you wanted to send to your patients, and I think that's so true, that we're really not alone, that we've got this great team of supporters where you work. Everybody else in the waiting room, as you said, is pretty much in the same boat in many cases, which leads me to the last thing that I want to talk about, which is, I know you're not a psychologist or a psychiatrist, you're a radiologist, but what about the emotional part of all of this? We've talked about the clinical procedures and the screenings and the things you need to do, and diet and some of those things, but what about the emotional part of getting a cancer diagnosis, for example, when things don't go well and there is a positive finding and then treatment starts, et cetera? What do you say to patients, or what would you say, or what would you recommend that families or friends do to be supportive? Because, as I said, I have a friend going through treatment now. I have a number of friends who are in different stages of breast cancer, and we always try to be as supportive as possible, but sometimes you don't know what to say, and sometimes the person's tired of talking about their cancer, for example. They just want to continue living their normal life and be the person that they were before cancer, even though they're a different person now. So I'm just curious what your suggestions or recommendations would be in terms of being supportive.
Well, I think that's well beyond my professional ken, but as a, as a human being and as a mother and a sibling and as a daughter and a friend, I think you just do what you can to be available to people and to try to sense what they need if they won't tell you directly. I think sometimes people don't know what they need. I tend to read a lot of stories and memoirs written by people who've been through things like this in order to try to better understand. I'm not sure that it's brought me to any new level of understanding, but it's okay to not have solutions for your friends. I think sometimes people think they need to have solutions when they contact a friend who's got a problem of any variety. But maybe just that phone call is all you really need.
I think that's true. Showing you care and also being a good listener, I think, is incredibly important, allowing that person to talk things through or to vent. One thing I will say is I have a friend who has stage 4 breast cancer, and she always says, and she's coexisting with her disease very well, and she always says that her cancer has actually given her certain gifts. It's given her the ability to feel more deeply and care more deeply and appreciate life more profoundly. And I'm just wondering if that's something that you see in your patients and something that you think is one of the good outcomes of being diagnosed.
I can't say that I know that, but I do think that is why memoirs of people who've been through things like this are interesting to me, because I think it's not uncommon for people to hear from people that when they receive bad news or difficult news or something that they know is going to change their life materially, that they become more focused, that they develop clarity about what's important to them in their life. And I think that it's unfortunate that one has to suffer sometimes for that.
Speaking for myself.
Life is not really about necessarily always controlling the outcomes.
Yes, that's so
But
true.
I do think that, as one of my friends says, it's not about, you can't change what happens to you, but you can change how you respond to what happens to you.
Yeah, I think that's so true. And your point about prioritizing, I mean, it definitely, I think, when you have something like what happened to me happen to you, it does force you to really look at what is most important, at least in my case. And it really, I think, also teaches you not to sweat the small stuff. I have a friend who's had 3 different types of cancer, and he's still working. He has 3 great kids. He's just an amazing, inspirational person to me. And he, does not get worked up over, little things that, like traffic in Boston or, being late for an appointment. Not that it's not important to be on time, but, some of the things that happen to us typically every day that we might get worked up over. I think when you have something that's life-changing, it can teach you to be a little bit more accepting of those small things.
I'm going to have to say that our patients here in the Brockton area, I think in general, have taught me that since I came here. It's amazing to me how wonderful the patients are that we care for here and how smart they are about life. And some of that may be developmental too. Do you think that when you get to a certain point in life, maybe for some of us it's aging, but for someone else, if they get a diagnosis that might limit their life, they get to that developmental stage a little earlier?
I think you're right about attitude. I think it can certainly bring out the best in many people. And I want to give people some information, by the way, if they want to come see Dr. Stafford. Or some of her wonderful team. They can go to Good Samaritan Medical Center. The Women's Imaging Center is at 15 Roach Brothers Way in Northeaston, Massachusetts. You can call them at the number that you just saw on your screen.
508-427 2850.
Thank you for saving me there. It was on the screen and then it disappeared, but obviously you know the phone number, which is terrific. So you feel that you've learned a lot from your patients then over the years?
Yeah.
Which is really
It's a
terrific.
great privilege to be permitted into the private lives of so many people over a career. And I'm very thankful for my 14 years I've spent here. It's been just a great place to work. My colleagues on the medical staff, my radiology physician colleagues, the people who do the work in radiology, all the technologists and the secretaries and the managers. It's an amazing group.
It takes a village, right?
At least,
which is what
yeah.
you've just described. It must feel great, though, to know that you're making a difference in people's health in what you're doing. I mean, to me, that would be one of the most fulfilling things to be involved in as a career and a vocation.
I think there are a lot of ways to support people in any career, and mine's been a lot of fun.
So let's talk about the future. We have just a couple minutes left, Dr. Stafford. What do you see as the developments down the line in radiology and screening? What's new and exciting in terms of the research that you're excited about? Because obviously you've seen many changes in your career, many developments already. What are you looking at down the road?
Well, I would say what's hot right now. What's hot right now in women's imaging, in terms of breast imaging, is abbreviated breast MRI protocols so that women aren't lying on the table for 45 minutes, and so it doesn't cost so much that you can't get your insurer to provide the service. So that's the number one hot topic today, is abbreviated MRI breast screening protocols. The American College of Radiology has recently recommended that for women who need additional screening because they're higher risk, that we go directly to MRI, and that we limit or eliminate ultrasound breast screening, which is something that people have been working with and toying with. Ultrasound breast screening right now is limited to patients who are not eligible to enter the magnetic environment. So people who have certain implants, people who have an aneurysm clip or something that's not safe in the MRI environment. But we recommend MRI for people who need additional screening. That's number one. So the abbreviated, less expensive protocols. Number two, I would say the adoption of tomosynthesis. If you look at the FDA numbers, the number of facilities that are acquiring tomosynthesis equipment is rising rapidly. I think right now about a little over half, almost 2/3 of facilities have at least one tomosynthesis piece of equipment. It's, I have to say, I did not realize how powerful it would be.
Tell us I know you talked about it in the beginning. Tell us what tomosynthesis is again.
It's a computerized 3D imaging technique, so
Okay.
that instead of, when a woman's having a mammogram, normally the tower where the radiation comes out is stationary. It does not move. Right now, if you have a tomosynthesis mammogram done, the breast is put in compression exactly as with the conventional mammogram, but the tower moves across an arc during the imaging process in order to collect the data that's then transmitted to a computer. A volume of data is collected and then slices are generated with the computer data so that you can, it doesn't really pull it out like a CAT scan, but it blurs the data on both sides so you see a slice that's sharp and then everything else is blurred.
Anything else that's hot and new? And
I think those are the two hot things for women's imaging.
you know, I'm glad you brought up, though, this issue of not, you said lying there for 45 minutes, the compression thing, which I think a lot of women feel intimidated by, but I think one of the great things about it is that it's over very quickly. When you go in to have a mammogram, it's a pretty quick process.
Should be.
Yeah. And the other thing that I picked up on earlier in our conversation is when you talked about the fact that typically when you go in to get a mammogram, you're going to get your results then and there in most cases. And I don't know if that's
That's
true or
for
not.
diagnostic imaging.
Okay, right.
Screening images, we normally don't give results at the time of the imaging. At our facility, you can schedule that service if you want. Personally, I think it's best to just go have your mammogram and let people take the time they need without the pressure of other things going on simultaneously. Let people have the time they need to look at your screening mammogram. It's an important test. You don't want to miss something, and you don't want to be pressured. So people who read their doctors who are reading screenings are not interrupted at our facility. We let them do their work.
Which is terrific. You know, I think it's this is something that's just anecdotal in terms of my own impression, and I realize that the treatments have improved greatly over the span of my life, for example, and that some diagnoses can be made more quickly. But it seems like there's less waiting, because the waiting part of a diagnosis is very painful. For example, when I was waiting for the results of my lymph node surgery, it took about 11 or 12 days for the pathology to, and it was a tough time. You know, I'm not going to lie to you, but it seems like doctors and nurses and all of those who work in this field are more sensitive to not having you wait, for example, over the weekend. They'll call you on Friday, and I don't know if that's something that that you actually strive to do so that people don't have to wait as long in your profession.
We actually don't call people on Fridays to tell them things or to ask them to schedule a follow-up because it's too stressful. We wait till Monday.
That's what I mean. Okay, so in other words,
if we know on Friday we need to call somebody back, we're going to call them on Monday.
Yeah, exactly. And that's kind of what I'm talking about.
Because we can't help them on Saturday.
Yeah, I feel like there's more sensitivity to the plight of the patient these days. And again, that's just anecdotal on my part, but I don't know if that's something that you talk about with with others in your field. Anything else you'd like to add? We have just under a minute, so any message you want to send to the audience about screening?
I would like patients to remember that in the Commonwealth of Massachusetts, you can order your own screening mammogram. You don't have to have an order from your doctor. Now, we're going to notify your doctor if you tell us who your doctor is, but you don't need to go and get a referral for a screening mammogram. You can go to any facility and make that appointment. And almost all insurers in Massachusetts cover a screening mammogram.
I was just going to ask about the insurance.
So it should be easier than you think.
All right, well, that's terrific advice. This has been a wonderful conversation. I've learned a lot. I feel like we could keep talking for a couple of hours, but really appreciate you being here.
Thanks
Dr.
so much.
Stafford.
It's great to meet you.
Absolutely wonderful to meet you, and thanks for giving us so much great information today. Have a great day, everybody. Thanks for being with us.
I'm tired.